and have thousands and thousands of members from all across the world. This basically is the Global Association of Physicians of Indian origin and have good representation from all over the world. We have had several meetings. We have midterm meetings as well as annual meetings. And the next meeting is being held in London. Indian Society of Gastroenterology is the premium professional organization of Indian gastroenterologists. And today we have the president of the Indian Society of Gastroenterology, Dr. Sandeep Nichavan, and the Secretary General of Indian Society of Gastroenterology, Dr. Matthew Philip, who are here to take us through this 1 hour journey. And we have my two colleagues, Dr. Anshul Sharma, who is a fellow DNB gastroenterology, who will be presenting one case, followed by Dr. Swayambhu Banerjee, who is a consultant in the Department of Gastroenterology at Apollo, Calcutta. So with this, I'll hand over the mic to Dr. Sandeep Nichavan for the initial comments. Dr. Jain from Indore, who is the advisor of Gapio, is supposed to join, but he just called me saying that he has some emergency in the family, so he may be joining a little late. But we can get going, and over to you, Dr. Sandeep Nichavan. Dr. Sandeep Nichavan knows no introduction to anyone in the gastroenterology. He is the head of the department of SMS Medical College, Jaipur, a very active researcher and a clinician, has published hundreds of papers, and has presently, as I said, is the president of Indian Society of Gastroenterology. Dr. Sandeep.
Yeah, good evening, Dr. Goenka and everyone. I bring greetings from Indian Society of Gastroenterology as a president. Basically, we are a growing family of gastroenterologists all over India, presently around 3,500. And our main focus of the society is on academic activities at various levels. We conduct actually national conferences, we do some state chapter conferences, we have midterm conferences of gastroenterology as well. And we have various programs at various levels. We actually do academic programs for residents in the form of GYM and YCP. Then we have train the trainer program for young budding faculty. During the COVID time, we also started doing master classes, which we are restarting now. And we have actually Indian Society of Gastroenterology journal with us, which is a prestigious journal in Asia Pacific region. And actually, we feel happy collaborating with Gapio, which is such a big society, as Dr. Goenka has just told us now. Today, what we have is presentation of usual cases of acute pancreatitis, and Dr. Matthew Philip and our Secretary General of Indian Society of Gastroenterology, and Dr. Goenka, who had been past president. Presently, he is very, very active in all these activities. They will actually take us through this meeting. So over to Dr. Matthew Philip and Dr. Goenka.
So Dr. Matthew Philip, as I said, is the Secretary General of Indian Society of Gastroenterology. He is at Leslie Hospital in Kochi, and he has active interest in IBD and therapeutic endoscopy. And of course, he is a very experienced gastroenterologist, both in the terms of clinician, research, and education. And we are happy to have him as the Secretary General of our Indian Society of Gastroenterology. Matthew, the flow today is that we'll have two presentations, and then if time permits, I will do a 5-minute presentation of approach to the etiology of acute pancreatitis, and then we'll leave about 10 minutes for question answer session. Over to you, Matthew.
Very good evening and greetings from Indian Society of Gastroenterology. As Sandeep was told, we are focused on academic research and guideline making, etc. And it's a very happy moment to have this collaborative meeting today. And I think, without much wasting of time, we straight away go to the academic program. I request Dr. Mahesh to start the program, and Dr. Sandeep, as well as Dr. Mahesh, to start the program. Let the first speaker come, and we'll have the presentation. Mahesh, how is the question answer happening at the end,
I think we can have some question answers after each presentation, maybe related to that particular topic, and then we can have additional question answers towards the later part. So what I have decided is that we can have about 20 minutes of presentation, and then maybe 2 to 3 minutes of question answer, and then again the second presentation. Anshul, are you starting first?
Yes, sir.
Okay, Anshul. So start.
Go ahead. Yeah.
Good evening, respected sir. Today, I'll be discussing a case of a 52 years old male with background of type 2 diabetes mellitus and hypertension for 15 years. And patient was on irregular medications, and there was no history of significant ethanol consumption. And there was his family history of ischemic heart disease in father. Patient presented to us with chief complaints of abdominal pain for 1 day, which was predominantly in upper abdomen, dull aching, continuous, radiating to back, and was aggravated by meals. Patient also had shortness of breath on exertion. There was no history of fever, vomiting, jaundice, or altered bowel habits. On examination, patient was found to be conscious, oriented 2 times less in person. Temperature was 97.5 degrees Fahrenheit. Pulse was 108 per minute. Blood pressure was 138 by 80 millimeters of mercury. Saturation was 97% with 10 liters of oxygen. Respiratory rate was 26 per minute. Xanthelasma was seen over bilateral eyelids, and on per abdominal examination was found to be distended. Bowel sounds was sluggish, and tenderness was present in the upper abdomen. So after the history and clinical examination, a provisional diagnosis was made of acute abdominal pain, visceral type, most probably originating from pancreas, associated with respiratory failure. We evaluated the patient with routine investigations, which included a hemoglobin of 14.4 gram percent. His liver function test was within normal limits. Amylase and lipase were raised to 712 and 1300 respectively. CRP was also raised to 39. On urine ketones were found to be positive. An ABG was done, which showed acidosis, and a chest X-ray was within normal limits. USG abdomen was done, which showed bulky pancreas with peripancreatic fluid collection, and there was no evidence of gallstones. We did CECT abdomen, which showed peripancreatic fat stranding with peripancreatic fluid collection and some hypo-dense areas in the body suggestive of necrosis. CTSI score of 8 by 10 was there. And after the history, examination, and investigations, a final diagnosis was made of acute necrotizing pancreatitis with CTSI score of 8 by 10, BASAP score was 2, Apache 2 score was 10, and modified Marshall scoring was 1 with type 1 respiratory failure. For etiological workup showed raised triglycerides and cholesterol to 3,477 milligram per deciliter and 630 milligram per deciliter respectively. And this patient was managed with IV fluids, analgesics, supplemental O2 support, and in view of hypertriglyceridemia as well as diabetic ketoacidosis, patient was initiated on insulin infusion. Patient was started on rosuvastatin plus fenofibrate as long-term pharmacological measure for hypertriglyceridemia. And on subsequent investigations on day 1, day 3, and day 5, it was found that triglycerides level were reduced from 3,477 to 325 milligram per deciliter. Cholesterol levels also showed the similar trend, and amylase and lipase levels also reduced. So etiologic workup of hypertriglyceridemia, it can be due to primary or secondary cause. Primary includes hyperlipoproteinemia type 1, type 5, or type 2B, 3, and 4. Type 1 and type 5 are more commonly associated with hypertriglyceridemia level of more than 1000 milligram per deciliter. And in secondary causes, included metabolic syndrome, obesity, hypothyroidism, nephrotic syndrome, glomerulonephritis, alcohol, pregnancy, multiple myeloma, drugs like thiazide, glucocorticoids, bile acid sequestrant, cyclophosphamide, beta blockers, cyclosporin, and tamoxifen. Now, coming to genetic contributors, common genetic mutations include lipoprotein lipase deficiency, ApoC2 deficiency, ApoA5 deficiency. We also sent clinical exome sequencing for this patient. The report is still pending. A few slides on acute pancreatitis, hypertriglyceridemia related. So hypertriglyceridemia is perhaps the third most common identifiable cause of pancreatitis after gallstones and alcoholism, accounting for anywhere from 2% to 50% or 20% of cases. The risk of developing acute pancreatitis is approximately 5% with serum triglycerides of more than 1000 milligram per deciliter and 10 to 20% with triglycerides of more than 2000 milligram per deciliter. Both primary and secondary disorders of lipoprotein metabolism are associated with hypertriglyceridemia-induced pancreatitis. Coming to pathophysiology, the pathogenesis of hypertriglyceridemia pancreatitis is unclear. However, the local release of free fatty acid by pancreatic lipase may damage pancreatic SNS cells or endothelial cells, and release of free fatty acid that induce free radical damage can directly injure cell membranes. Typically, three types of patients develop hypertriglyceridemia-induced pancreatitis. One is the poorly controlled diabetic patient with a history of hypertriglyceridemia. Second is the alcoholic patient with hypertriglyceridemia detected on hospital admission. Third is the non-diabetic, non-alcoholic, non-obese person who has a drug or diet-induced hypertriglyceridemia. Meta-analysis of 15 studies found a worse prognosis in patients with hypertriglyceridemia compared with the non-hypertriglyceridemia causes of acute pancreatitis. So coming to management, if a diagnosis of acute pancreatitis is established with triglyceride level of more than 1000 milligram per deciliter, we should also evaluate for other causes. And if no other causes found, triglyceride can be attributed to hypertriglyceridemia. So we should start patient with conventional treatment with IV fluids and symptomatic treatment. And patient should be started on insulin infusion. Heparin infusion is not recommended. And if the patient is found to have severe acute pancreatitis with Apache score of more than 8 or there are multiple organ dysfunction, then we should, if the non-pharmacological therapy like plasma exchange is available, then it should be initiated as soon as possible with albumin as a replacement and citrate anticoagulation till triglyceride levels are less than 500 milligram per deciliter. And if the multiple organ dysfunction are not there, then we can continue with the conservative management with insulin at the rate of 0.1 to 0.3 units per kg per hour. And once patient can tolerate, we should initiate anti-triglyceride agent as soon as possible, like fibrates and statins, and complications are to be monitored and treat accordingly. There was one multi-center prospective cohort study. It was carried from 2015 to 18, published in Pancreatology. Three centers from India were part of it, in which one was Apollo Institute, Apollo Multi-Speciality Hospital, Kolkata, and it was found that out of 1,478 patients, 69 patients diagnosed with hypertriglyceridemia-related acute pancreatitis, found to be the fourth most common etiology of acute pancreatitis. And in this study, the clinical outcomes were similar compared to the other etiologies. And the take-home message, hypertriglyceridemia may be associated with severe pancreatitis as compared to other causes. Aggressive lifestyle modification should be done to prevent further episodes of acute pancreatitis, and patients with familial disorder should be counseled, and triglyceride levels should be monitored on a regular basis. Thank you.
Thank you.
Very, very nice presentation. Can I ask one or two questions?
Yeah, sir. You have already asked a question in the chat box.
Yeah. One is regarding the prognosis as compared to alcoholic pancreatitis. How is the prognosis in cases of severe pancreatitis?
Sir, It's written in few texts that the patients with hypertriglyceridemia have worse prognosis compared to the other causes, as the more necrosis is found in these. And as I included one study, which was a multi-center study, it showed the outcomes were similar to the other cause.
And why it's not indicated? One of the therapy for decreasing triglyceride giving heparin.
Sir, actually, heparin acts by increasing the release of lipoprotein lipase from endothelial cells. So after it can lead to the rebound hypertriglyceridemia as the lipoprotein lipase are depleted, and there is also increased risk of bleeding. These.
There is a question by Sharad Dev that is on what was the precipitating event of pancreatitis in this patient, as hypertriglyceridemia would have been there for long standing, and what was his HbA1c? Did you understand the question?
Yes, sir. The patient presented with abdominal pain radiating to back. Patient was not known to have hypertriglyceridemia. He was not investigated earlier.
The question, what I understood was that what precipitates an acute attack of pancreatitis in a patient who has hypertriglyceridemia? Is that what you are saying? Anshul, you have an answer to this?
No.
I think it is just like alcoholic pancreatitis. Somebody may be taking alcohol for a long time, and at some episode, something happens which causes an acute episode. I think it's something like that only. Whether it is an acute increase in the hypertriglyceride value at that particular time or some added insult, really we don't have an answer.
Yes, probably there may be another insult which happens. We are not sure. See, I just want to ask another question to you. You know that alcoholism is quite common in producing acute pancreatitis. It's also is quite common to increase the triglyceride value. So a patient is admitted with alcoholic pancreatitis, and the patient has got a high triglyceride value. Then how do you differentiate these two? And one more thing is that another question which is almost similar things that asked by Dr. Vikram Uttam. Is a single value will suffice? And at what time you do triglyceride value on the time of admission, or at what time you do? And if you want to repeat, at what frequent intervals, intervals you want to repeat those values?
Sir, first question answer. The alcohol can lead to hypertriglyceridemia, but usually the levels would not be significantly raised, like more than 1,000. And secondly, hypertriglyceridemia should be checked on the day of admission, because pancreatitis itself can lead to hypertriglyceridemia. So we should do it as early as possible.
How frequently you repeat it? Only one value sufficient? Suppose you get a value of 1,000 on the day of admission, and are you happy with that, or you want to repeat that value after a few days?
No, sir, with treatment, we should repeat on subsequent days to look for the decrease in the levels.
I think what possibly is an answer is that if the value is more than 1,000, you can more or less diagnose that this patient has pancreatitis because of hypertriglyceridemia. But if the value is borderline, then one may repeat, because we know that even in a normal pancreatitis, there may be increase in the triglyceride value, but usually it will not go beyond 1,000.
And one more thing, what was the HbA1c of this patient at that time?
Sir, HbA1c was raised. It was 8%.
Okay. Any other question, Mahesh? Any other question pending?
There is another question, is that any difference in the outcome in case of hypertriglyceridemia induced pancreatitis? The answer is most of the data. Anshul, will you like to answer that question? What is the outcome? Is the etiology decides the outcome?
Sir, in some in text and some articles, it is written that hypertriglyceridemia related pancreatitis are more severe compared to the non-hypertriglyceridemia related. But in one of the study, it was shown that the outcomes are more or less similar to the other
and
etiologies.
moreover, Moreover, actually,
So-
the outcome of pancreatitis decides upon the severity of pancreatitis rather than on the etiology. But no, as you said, probably this could be, in some cases, it could be very bad.
Most of the data when we reviewed shows that hypertriglyceridemia induced pancreatitis tends to be more severe. And so since it is more severe, the outcome is usually worse. But the article which Anshu quoted, in which we were one of the 3 Indian who had contributed to the cases, I think the total number of cases, Anshu, if I remember, was around 75 or 76, which were related to hypertriglyceridemia. And we could not demonstrate a worse outcome in patients with hypertriglyceridemia. As rightly pointed out by Dr. Matthew Philip, I think the ultimate outcome will depend on the severity of pancreatitis.
And what is the role of hemoabsorption filters? Any role on this?
Yes,
Flex has been found to be very useful, but what is the role on these filters, hemoabsorption filters?
Yes, sir. Hemofiltration and are useful in the hypertriglyceridemia patients.
And what is the chance of them to get recurrence on patients with this syndrome? What is the chance of recurrence for this patient? Or how do you treat this patient? They're lifelong. They should be on treatment.
Yes,
for. And I think that is quite important.
So I think Matthew, the answer would be that if it's a familial hyperlipidemia, then you will need to treat the patient lifelong with both the diet modification as well as the antilipidemic drugs. But if it is because of a secondary cause of hypertriglyceridemia, as it can be caused by the drugs and many other diseases which Anshu has talked about, then maybe that you take care of that particular etiology and you don't need to treat the patient subsequently. Of course, as asked, in a setting like this, we should investigate the relatives to find out whether there is a familial hyperlipidemia, and if yes, which category does it fit into for the various types.
If there are no further questions, can we move to the next one?
There is a question about heparin infusion. I think in general, heparin we used to give earlier days, but now heparin is not indicated in any patients because it has been found that there is a rebound increase in the triglyceride level after the heparin therapy. So heparin is no more mentioned as one of the modality of treatment for triglyceride-induced pancreatitis.
Mahesh,
I think, yes.
One more thing is that in these patients, we have to make sure that the hyperglycemia is controlled well, because that also will add to this hypertriglyceridemia.
Agreed. Now, a point which I missed some of the slides of Anshul, which must be again emphasized, that if there is a setting of acute pancreatitis, the amylase may not rise in the presence of hypertriglyceridemia because of it interferes with the measurement of amylase value. So if there is a classical setting, and if amylase is not raised, then one should do imaging. This is one rare situation where imaging may be done in the early days of the acute pancreatitis to confirm the diagnosis because amylase may not rise.
They can also do on dilution. No, we can do on dilution.
Yes, correct. So I think should we move on to the second presentation, Matthew? Thank you, Anshul.
Thank you, Anshul.
Second presentation by Swambhu Banerjee, who is my co-consultant in the Department of Gastroenterology at Apollo Multispecialty Hospital. He'll be presenting another interesting case of acute pancreatitis. Swambhu.
Am I audible, sir?
Yes.
Yes.
So I would like to, first of all, I would like to take this opportunity to thank Dr. Goenka sir and Isg and Gapio leadership for giving me this opportunity to present this case. We'll move on to the case presentation. So this is, the patient is a 50-year-old male with no comorbidity. He had a pain in anterior aspect of the left leg for 3 months, for which he was evaluated by the orthopedic surgeon outside. X-ray was done, which showed multiple cortex-based expansile lytic lesions in left tibia. Given his age, there was the possibility of malignant disease as well as benign diseases were considered. In malignant diseases, metastasis and multiple myeloma were considered, and in benign diseases, non-ossifying fibroma was considered. A bone scan was ordered, which showed diffused increased pressure uptake in multiple areas like skull, ribs, pelvis, also in the middle third of the left tibia, along with the no tracer uptake in kidneys, raising a possibility of either a metabolic bone disease or else metastasis. Multiple myeloma workup was done, which was negative. By this time, the patient presented with complaints of severe continuous dull aching abdominal pain radiating to back, associated with multiple episodes of vomiting. Pain was aggravated with meals and relieved on leaning forward. It was not associated with fever, jaundice, or altered bowel habits. There was no relevant family history, no history of any drug intake, no history of any addictions. On examination, there was SIRS features which were present in the form of tachycardia, tachypnea. Abdomen was distended, epigastric tenderness was present, and the peristaltic sounds were absent. Labs showed an elevated amylase and lipase more than 3 times upper limit of normal, raised alkaline phosphatase more than 10 times upper limit of normal. Corrected calcium was raised 12 milligram per deciliter, and serum phosphorus was low, 1.3 milligram per deciliter. Other laboratory parameters were within normal limits. A serum PTH assay was done, which was shown elevated PTH level, 1,654 picogram per ml, and the 25 hydroxyvitamin D was normal. Evaluation of hyperparathyroidism was done. A USG neck showed a 3 into 3 centimeter hypoechoic, well-circumscribed ellipsoid SOL in infrathyroid region, right neck. A technetium system-AB scan was done. So in the first image, this is the plain technetium image where the thyroid glands are, tracer uptake is present. And the second tracer is the technetium system-AB tracer, in which we can see that how it is done is they actually subtract the first image from the second image. And in the third image, we can see that there's a hyperfunctioning nodule involving the right lower pole of the thyroid gland, which is the suggestive of parathyroid adenoma. So further images showed chest X-ray was within normal limits. USG showed there was no evidence of gallstone. CBD was not dilated. MRCP revealed bulky pancreas with altered signal intensity, as well as peripancreatic fluid collection. A contrast CT abdomen showed bulky edematous pancreas with peripancreatic fat stranding, along with a peripancreatic fluid collection, giving rise to the modified CTSI score of 4. There was no evidence of pleural effusion or ascites. The bone window, as we can see here in the second image, showed multiple lytic lesions in pelvis. So a diagnosis of acute moderately severe pancreatitis was made, etiology being hypercalcemia secondary to primary parathyroid adenoma. There was no organ failure, and the lytic bony lesions which we saw was Brown's tumor. Coming to the management, the patient was managed with IV fluids and IV analgesics, and after adequate hydration, diuretics were added. Injection pamplonate, that's a bisphosphonate injections were given as the patient had a persistent hypercalcemia even after adequate hydration and forced diuresis. And the patient, surgical consultation was sought, and patient was planned for right lower parathyroidectomy with serial intraoperative PTH estimation plus frozen section. A brief review of this topic, pancreatitis secondary to hypercalcemia. So hypercalcemia is a rare cause of acute pancreatitis. Less than 1% of the cases are attributed. Amongst all causes of hypercalcemia, primary hyperparathyroidism is the most common. Western studies have shown a pancreatitis prevalence in primary hyperparathyroidism ranging from 1.5 to 8.5% cases. Most of the cases were in the age group, older age group of about 50 to 60 years. In contrast to that, studies from India have reported higher prevalence of pancreatitis in primary hyperparathyroidism patients, 12.9 to 16% cases, and most of the cases were young males. Patients who had primary hyperparathyroidism had 10 to 30 times increased risk of developing acute pancreatitis during their disease course. And acute pancreatitis secondary to malignancy related hypercalcemia confers a poor prognosis. About 40% cases develop severe acute pancreatitis with a mortality rate of around 30% in those cases. The most common malignancies are parathyroid carcinomas and the multiple myelomas, which are attributed. These are the major major international and Indian series in primary hyperparathyroidism related pancreatitis. We can see here, what we can see here is that in the world literature, the cases of acute pancreatitis and chronic pancreatitis are fairly equal. But in Indian series, it's almost the rate of acute pancreatitis almost double. If we combine this data, there's about 38 cases of acute pancreatitis versus 19 cases of chronic pancreatitis which were reported. So in India, the acute pancreatitis is more common. Coming to this, what we can see here is the case series where the coexisting etiologies were not excluded. In about 30 to 40% cases, there were concurrent etiologies which are present, like gallstones, alcohol, triglycerides, which should be investigated during the disease course. Also, an interesting fact is that the resolution of pancreatitis after parathyroidectomy is almost 100% in cases of acute pancreatitis. But in cases of chronic pancreatitis, what we see here is that the disease course of the natural history of the disease is not altered much. That is why in this case series from France, we can see that about 50% of the cases were actually about 55% of the cases were acute pancreatitis, and rest 45 was chronic pancreatitis. And here we can see the resolution of pancreatitis after parathyroidectomy was in the tune of about 40%. So coming to the mechanism of development of pancreatitis in primary hyperparathyroidism. So exact mechanism could not be elucidated, but the postulated mechanisms are elevated extracellular calcium levels, augments in intracellular calcium signaling, and activates the pancreatic proteases, especially trypsinogen, leading to the initiation of the pancreatic inflammatory cascade. Deposition of calcium-rich protein plugs can lead to the formation of pancreatic calculi, ductal obstruction, and subsequently chronic pancreatitis. And in one study from Germany, it has been shown that the primary hyperparathyroidism patients with AP had higher prevalence of mutation in SPINK1 and CFTR genes in the tune of about 16%. These are the therapies for severe hypercalcemia. So the first line therapies are hydration with normal saline, followed by addition of a loop diuretics. And the next thing what we do is that we add bisphosphonates. Bisphosphonate takes about one or 2 days to act, so it is not very useful in the acute hypercalcemic crisis setting. The other therapies which are used are calcitonin, which are again used in severe hypercalcemia. Immediately takes action, and but it's only useful in first 2 days of treatment, because first 48 hours of treatment, because it has got a rapid tachyphylaxis after that. And of course, in glucocorticoids are used in where the etiology is granulomatous disease or vitamin D excess. And dialysis can be of use in severe hypercalcemic crisis where other conservative therapies fail. So the take-home message which I'd like to give is that patients with primary hyperparathyroidism associated acute pancreatitis were younger, had a male preponderance. Any patient with pancreatitis and high normal or elevated serum calcium levels should be investigated for primary hyperparathyroidism or any other etiology of hypercalcemia. Patients should be investigated for concurrent etiologies in primary hyperparathyroidism related acute pancreatitis. Early diagnosis and resection of parathyroid lesions will prevent recurrent attacks of AP and other primary hyperparathyroidism related complications. Thank you.
Matthew, can I just briefly present a 5 minutes presentation?
Yeah. Then we'll take it.
Can I be allowed the sharing screen, please?
I request the participants to post their questions in the chat box so that we can have discussion on that. So it was presented a wonderful case, and it's one thing which any pancreatitis, when we do a calcium, many times it is low, but if it's high normal or high, then we always should rule out the causes of hypercalcemia as causing acute pancreatitis. Mahesh, please.
Yeah, just let me see if I can share my screen. Otherwise, you can take up questions in the meantime. Are there any questions?
I think it is single value. There was a question on IV fluid management. In this patient, RL was not given. Am I right, Swayambhu? What was the fluid therapy for this
Yes, sir. Actually, in this patient, we preferred normal saline.
Because of hypercalcemia?
Yes, because of hypercalcemia, sir.
Yeah. Because for a treatment of hypercalcemia, you require a high infusion of normal saline, but I'm not sure about whether it is detrimental in patients.
My slide seen there?
Yes, now we can see.
So I'll just briefly tell in 4 to 5 minutes as to what should be the approach for etiology diagnosis of acute pancreatitis. And it's just about 7 or 8 slides. I think it depends on what age group we are dealing with. It also depends on what are the availability of various investigations which you have, and how many attacks of acute pancreatitis has already taken place. Usually the textbook teaching is that anybody who has more than one attack of acute pancreatitis should be investigated for the etiology, but I think it will depend on a case-to-case basis, and you may have to do it even after the first episode. So the basic steps I would be discussing in 3 steps. The basic steps would give us an etiology in about 70%, additional investigation about 20%, and few idiopathic would remain in spite of all the investigation about 10%. So the basic investigations will include comprehensive history and examination, as was depicted in 2 cases. Medication review is very important because a lot of medicines can cause acute pancreatitis, and initial investigation should include LFT, triglyceride, and calcium. And these 2 cases demonstrate the importance of doing these tests. And non-invasive imaging, which should be cross-sectional imaging. This is a list of various drugs which should be looked for. And the common one being furosemide, isoniazid, metronidazole, tetracycline, amiodarone, acetaminophen, azathioprine, and so on. So you must look for the drugs. The second group of investigations would be EUS, MRI with MRCP. One should repeat in calcium and parathormone. And this was discussed as to the triglyceride should also be repeated. Now, whether one should do an EUS or an MRCP as the next investigation is subject to question. We understand that when you do look for, when you do an EUS, you may find the evidence of chronic pancreatitis, as in this case. You may find microlithiasis, classical starry sky appearance. You may find a small stone in the bile duct. You may find a tumor in the pancreas, and you may find ascariasis in the gallbladder or the bile duct or the pancreatic duct. Overall diagnostic yield of MRI and MRCP is 60 to 80%. Ultrasound EUS is 60 to 80%, but it should not be done immediately after an attack of acute pancreatitis. Ideal time would be to give at least a couple of weeks before you do this EUS, because the lesions may be missed or misinterpreted in the acute attack. Now, MRCP is valuable, particularly in this situation: pancreas divisum, anomalous pancreatico-biliary ductal union, choledococele, and of course, chronic pancreatitis. Security in MRCP is better than normal MRCP. Now, this is an article published in Gastroenterology this year, which said that after an unrevealing initial evaluation, EUS is a preferred diagnostic test for unexplained acute or recurrent pancreatitis. MRI and MRCP can be an additional or an alternative modality. Now, it has been shown that more you investigate, the amount of idiopathic pancreatitis shrinks over as you do more and more investigation. So before investigation, before advanced investigation, this series had 35% as idiopathic, but after investigation, it was reduced to 15%. The 2 additional tests which can be done, though not very commonly in our country, is cystic fibrosis, sweat chloride test, and genetic studies. We know that pancreatitis can be associated with various types of genetic abnormalities, and doing the genetic studies can at least reassure the patient that we are not missing any other diagnosis. What is the role of doing an IgG4? We must understand that acute pancreatitis occurs more commonly in type 2 autoimmune pancreatitis or type 2 IgG4 disease. And so IgG4 is usually not elevated in this subset. So doing an IgG4 may not be very productive. Etiological investigation is very important because a lot of etiological intervention is possible: stopping smoking and alcohol, microlithiasis, colorectal cyst, hypercalcemia, hypertriglyceridemia, tumors, AIP type 2, drug-induced pancreatitis, and the entity which we did not talk about is sphincter dysfunction. So these are important so that you find out the etiology and prevent recurrent attacks of pancreatitis. Thank you very much. I will end at that point. Thank you.
Thank you, Mahesh. And it was
you can continue with the communication and discussion, please.
It was a wonderful, short, quick review on the workup of acute pancreatitis. Just a quick question. There have been a lot of studies and recommendations to look for biliary microcrystals on deodal aspirate. Does people do that now?
Now, I think once the US and a very advanced EUS have become available, I think the use of doing microlithiasis, which is a very cumbersome test to do with a lot of issues with sensitivity, I think it's becoming less and less popular.
I think the one important message, what Mahesh has told, that when you want to do an imaging, I think when compared to MRCP, EOS is better yielding, and also you can intervene if there is a stone in the bile duct, and also you can assess the morphology of pancreas by doing an endoscopic ultrasound. It's a very good message, and I think that is the common practice in most of the gastroenterology centers now. I think we can take up questions for Swayambhu. The question was, some of the questions you have already answered in that.
Yes, sir.
See,
basically, RL is not used because RL has got calcium in it, about 2.7 milliequivalents per liter. And another question was whether intact PTH should be measured or the whole PTH. So actually, the intact PTH assay measures both the fragments. There's 184 fragment and the 784 fragment. So that's more accurate. So that's why usually the intact PTH assay is preferred in these cases. So the question was, another question is when hemodialysis should be considered. Yes, so hemodialysis should be considered in case of severe hypercalcemic crisis, where there is organ failure and severe hypercalcemia, which does not respond to the first line therapy of IV hydration, followed by diuresis. And what we have to know is that only two modalities act in the acute phase, that is IV hydration and serum and salmon calcitonin. But if those two fail, then we should go for hemodialysis.
I think it is not a bad practice to examine the patient with acute pancreatitis, especially those who are coming with recurrent acute pancreatitis, and if the calcium is on normal or high, to palpate the patient's neck also. And yes, many times you can actually palpate a nodule in the neck, and doing an ultrasound in the neck, by a radiologist using a high frequency probe will also be sometimes very useful to pick up that. And is in these patients, the questions is about that which one is better for pancreas diffuse EOS or ERCP? Definitely MRCP is superior because that produces a good imaging and you can try to identify. EOS also can recommend, it could be complementary, but you have to be very careful when you interpret pancreas diffuse in EOS. You have to look very carefully for that, but definitely you can make a diagnosis in EOS also. But mostly people, what they try to do is they do a MRCP, which is found to be better for that. But there is no head-to-head trial, but in our practice, we usually use MRCP, and that we take as a guide for when we do EOS. What level, another question is by Surya to Swayambhu, what level of corrected calcium level is a risk factor for acute pancreatitis?
So it has been shown that every 1 milligram above normal increases the risk 1.3 times, basically, of pancreatitis.
Thank you. That is another question is on glycemic control. Is it very essential? Is it for, I don't know whether the question is actually interested to, I mean, it was for hypercalcemia related to pancreatitis, or it is for hypertriglyceridemia. Hypertriglyceridemia is quite important that you want to control the blood sugar very well. What about hypercalcemia, Swayambhu?
Sir, I think it doesn't have a direct correlation, but as we all know that hyperglycemia the glycemic management should be appropriate to prevent secondary infections during the in-hospital course.
And Dr. Indrajit Tiwari has asked whether SLED is better or CRRT is better.
So actually, any methods of hemodialysis would take care of hypercalcemia, but the rate of correction is obviously higher in hemodialysis as compared to SLED or CRRT. But in hemodynamically compromised patients, we would like to go for SLED or CRRT in these cases.
In patient who is actually in hypertension and all, then you have to go for CRRT, and but you have to see
absolutely, and calcium-free dialysate as told.
And CRRT is more expensive also. We have to realize that.
Exactly.
Calcium-free, that is, Indrajit has answered that, calcium-free dialysis.
Right.
Calcium-free dialysis. Any other question you want to make? Any other comments on this?
So another question is the common secondary causes of hypercalcemia to look for in these patients. So secondary hyperparathyroidism can be one cause. So actually that is why the PTH assay is very important in these patients. So once the other causes being, of course, secondary hyperparathyroidism, which can be due to CKD, and then the other causes being thyrotoxicosis, vitamin D toxicity, any granulomatous disease, multiple myeloma, any malignancy causing metastasis. So these are all the other causes which can lead to hypercalcemia related pancreatitis. In the studies, it has been shown that after primary hyperparathyroidism, next most common was malignancy. In the malignancies, parathyroid malignancy as well as multiple myeloma is most common.
And in a case of acute pancreatitis due to hypercalcemia, at what time, what stage you will do for parathyroid adenoma surgery after acute pancreatitis?
So after resolution of the pancreatitis, sir, of course, after resolution of the pancreatitis, because to prevent further attacks of pancreatitis and as well as to prevent further complications, renal complications, as well as bone-related complications, we should go for surgery.
I think surgical management of parathyroid adenoma is essential because to prevent recurrence of recurrent acute pancreatitis, or even they can develop chronic pancreatitis. And in those, I have experience in patients who have been very sick and not suitable for surgery. We have even used ablation, RFA ablation or alcohol ablation of parathyroid adenoma in patients with pancreatitis. But one thing is true, though it is very rare, sometimes, you should be vigilant to look for these things to make a diagnosis.
Absolutely.
Otherwise, you will miss. But all cases of acute pancreatitis should have a calcium value. And if the calcium is normal, then you should alert that am I dealing with hypercalcemia? Because even those patients, of course, overtly that is hypercalcemia, there is no doubt it is hypercalcemia. Even in patients with reasonably severe pancreatitis, if the calcium is normal or high normal, then you should actually get alerted.
Absolutely, sir. Absolutely. So one more question.
Mahesh is back. Mahesh?
Yeah, I'm in and out. There's another meeting going on parallel.
Yeah. Okay. So
I think excellent comments. Somebody asked about role of steroids.
So the role of steroid is only in cases of hypercalcemia secondary to granulomatous diseases like sarcoidosis, or in the cases of vitamin D toxicity. In those cases, glucocorticoids is indicated.
I think, there were actually both the presentations were wonderful, and it's very interesting and quite practical. And the presentations were really good. And you actually showed us that, how these metabolic factors are quite important as etiological factors of acute pancreatitis, and how these can be detected and managed. So it was really good. And I'm so it was wonderful to present such a very interesting case of hypertriglyceridemia and how it was managed. And there are a lot of questions on that. I'm sure still maybe if we wait, there may be more questions coming up. And the participation by the audience was really wonderful. And they put on a lot of questions. And Soimbu, you have done a wonderful work and the presentation was extremely good. And the workup of the case actually shows that how high quality work is being done in your institutions and how vigilant you people are in trying to find out the etiological workup in patients with acute pancreatitis. So let me ask one question to Mahesh. What percentage of your patients in recurrent acute pancreatitis, you select them for genetic studies?
For genetic studies?
Yeah.
Yeah, I think all patients after the workup has been, the initial workup is negative. We would try to do genetic studies because it serves two purposes. One, it makes us stop investigating again and again for the underlying etiology. So if we find a genetic abnormality, we now know that there's an association is clear. And number two is it's also helps in possibly looking at the families and evaluating them for similar genetic studies. But at this moment, there's no intervention which is possible because of the genetic studies. So we would do in all patients, we would try to do if we have exhausted our investigation and not found any cause. So I must also thank Matthew and ISG, of which I'm also an active participant for joining for this meeting, and we can have more such meetings in future.
Thank you. And
thank you, Matthew.
There is one more question by Dr. Vikram Uttam, that is on which patients of hypertriglyceridemia should we suspect familial dyslipidemia? Should we screen on? If yes, which gene test genetics should be done? I think Anshul has shown the slide on genetic testing. Anshul, you want to
So actually, all the patients moderate to severe patients with moderate to severe hypertriglyceridemia, where the triglyceride level is more than 500, should be screened for familiar hypertriglyceridemias. And
on Mahesh talk, after how many episodes of acute pancreatitis, you should actually work up for these patients for etiology. And generally, we consider that after one episode of pancreatitis, one episode is considered recurrent acute pancreatitis. But I tell you, in those patients, there is no obvious risk factors, and especially elderly people. If they have got first episode of pancreatitis, and you should actually work up for etiology. You should rule out gallstones, you should rule out drugs, you should rule out alcohol, and all those factors. But you should see that there could be an obstructive pancreatitis. We have seen patients with ambulatory cancer. We have seen patients with the carcinoma head of pancreas presenting with acute pancreatitis. Even sometimes IgG4 disease can, though it is rare, that can present with acute pancreatitis. I think these are all very important. And if there are no first, there is.
I have a small question, which is little off the topic. I would like to ask you, sir. So actually, in patients in which after workup of acute pancreatitis, only the GB sludge comes. What's your take on that for those patients regarding need of cholecystectomy? And
see, in a patient who is fasting for so many days, when you do an ultrasound, you can see GB sludge. So what I do is, you just wait for some time. If the GB sludge disappears, that's fine. Or if the patient's GB sludge still remains, then those patients should be subjected for this one. And we know that any patient who has got acute pancreatitis, if it is biliary, the liver enzymes, the liver function test should be abnormal in those patients. So without having an abnormality of liver function test, only presence of GB sludge, I think you should be very careful in labeling it as case of biliary pancreatitis. There is one more question. What is the role of, that is from Balma Kudu, from Bala, that is the role of anesthetist or ITU. What is the role in acute pancreatitis?
So I think it's a very crucial role which it plays, sir, in acute pancreatitis, because cases of severe acute pancreatitis, the initial management it matters a lot. So I think it is very crucial.
I think in any severe acute pancreatitis goes into ICU and it's seen by the critical care person. That's very, very important also. And is there a role for doing an ANA testing in patients with acute pancreatitis? Who want to take up, Anshul or?
I don't think so, sir. I don't.